As a caveat, I'll let you know that this is not my presentation. It comes from NEDA, the National Eating Disorders Association. So I'll have my nose in the book as I go through the information. My name is Davalos-Matthews. I'm a mental health wellness counselor here on campus. I work with students only. Sorry. I get called a lot to see if I can help out our faculty and staff, and always refer to our EAP program for that. So as a licensed professional counselor here, I have some training in eating disorders, but I am not a specialist in eating disorders by any stretch of the imagination. As I mentioned before, some of you came back. We'll be on Zoom, just in case there's anybody that wanted to Zoom in, which doesn't look like there are. And we'll also be recording this as a still healthy event for faculty and staff to watch later. So if you're watching already, sorry I'm taking time to get started here. So our Eating Disorders 101 program is going to cover the causes, warning signs, symptoms, health consequences, and treatment information. This is a dense program, and in 45 minutes can't really do it complete justice. So if you want a copy of the PowerPoint slides with the notes, there's a sign-up sheet in the back. Just put your email address. I'll send it to you as a PDF. There's also a toolkit for educators, which I think is good for everybody, on how you can talk to other people about eating disorders. The slide deck was put together by the National Eating Disorders Association. If you have questions, you can visit their site, and you'll see that pop up on every slide at the bottom. Some of the topics we'll be covering may be difficult for people to hear. Please feel free to take a break if you need to. If this hits too close to home and you need to step out for a minute, that's okay. Just kind of give me a sign whether you're coming back or you're not coming back, and then I'll know whether or not maybe I should worry. Maybe I need to check in on you later. Okay? Hi. Come on in. You don't have to sign in if you want a copy of the slide deck or you want a copy of the toolkit. You can sign in there and put your email address. But for Still Healthies, we no longer have to sign in. All you have to do is go to the website. I don't know what it is, but go to the website and click that you attended and give them the name. All right. So the first question usually is, what are eating disorders? And eating disorders are real diagnosable disorders of the body, mind, and spirit, hence the term biopsychosocial. And they often have very serious and potentially fatal consequences. People with eating disorders experience extreme emotions, beliefs, attitudes, and behaviors associated with food, eating, and exercising in their body image. Who do eating disorders affect? Pretty much anyone. People of all ages, genders, races, religions, ethnicities, economic status, and sexual orientations can be affected. As many as 20 million women and 10 million men struggle with eating disorders at some point in their lives. It is a false belief that eating disorders are diseases of privileged white women. While eating disorders do affect young women, they also affect men, transgender people, people of color, and so on. To kind of stereotype eating disorders as only affecting one segment of the population is a disservice to the diverse groups of people who are affected by eating disorders, and perpetuates a stigma that people might feel that would prevent them from getting help. Eating disorders, as I said, are complex biopsychosocial conditions with multiple causes. Eating disorders arise from a combination of established social, psychological, biological, and interpersonal factors. While they may begin with preoccupations with food and weight, they are most often about much more than just food. Oftentimes, control is a big issue for people who have anorexia. There will be co-occurring disorders that we'll also mention later on. It's important to understand that the factors that contribute to eating disorders are complex and multifaceted, and they are not simply about weight, and they are certainly not a choice. Hello, Beth Poppery. I would like to go back to my screen now. Share screen. There we go. So there are 9 truths about eating disorders. There's varying opinions about eating disorders, but the field has basically agreed on these 9 truths. Many people with eating disorders look healthy, but may be extremely ill. Families are not to blame and can be the patient's and provider's best allies in treatment. And an eating disorder diagnosis is a health crisis that disrupts personal and family functioning. Eating disorders are not choices, but serious biologically influenced illnesses. There is possibly a genetic component. Eating disorders affect people of all ages, races, genders, ethnicities, and eating disorders can increase risk for both suicide and medical complications. Genes and environment play important roles in the development of eating disorders. Genes alone do not predict who will develop an eating disorder. And full recovery from an eating disorder is possible. Early detection and intervention are extremely critical. On to warning signs, symptoms, and health consequences. The common warning signs, as the list describes some of the general warning signs of an eating disorder. Detecting an eating disorder can be extremely tricky, with a big indicator being a noticeable change in a person's attitude towards food and their body. While there are more specific signs depending on diagnosis, not everyone fits neatly into these categories. So there are sort of catch-all categories for some of the nondescript varieties, and there may be a lot of people who don't necessarily meet the criteria for an eating disorder, but still have disordered eating. And those folks need attention just as much as people with a diagnosable condition. I'm going to go ahead and show you this video that will cooperate. Maybe. Or not. When you get this, you can watch it. It's fairly long, and it's mainly focused on anorexia, but a lot of the information on anorexia is also similar to the other eating disorders. So we have basically 5 main categories for diagnoses: anorexia nervosa, bulimia nervosa, binge eating disorder, avoidant restrictive food intake disorder, and other specified eating or feeding disorder, feeding or eating disorder. The term eating disorders covers a variety of conditions. What they all have in common is the extreme emotions, attitudes. A little delayed. I think this is one of the slowest computers in the university. There we go. All of them involve extreme emotions, attitudes, behaviors, and surrounding weight, food, and size. Eating disorders are rooted in a uniquely low self-esteem and disruption of one's relationship with themselves. Eating disorders are extremely serious and potentially life-threatening. They have both emotional and physiological effects, and they can affect anyone, again, as we've said before. The eating disorders we'll be talking about here some conditions that are not listed here, such as atypical anorexia, we'll kind of cover a little bit later, but just understand that there are more subcategories than what we're just looking at here. We won't be able to cover everything, but we do encourage you to look them up further. So for anorexia nervosa, it's most likely the best known eating disorder. It's primarily characterized by self-starvation. The primary symptoms include inadequate food intake, disturbance in the experience of body weight or shape, intense fear of weight gain, and an inability to appreciate the severity of their own situation. Warning signs can include dramatic weight loss, preoccupation with weight, food, calories, and dieting, refusal to eat certain foods, progressing to restrictions against whole food categories, consistent excuses to avoid meal times or situations involving food, not wanting to eat with people, withdrawal from usual friends and activities, and inappropriate or extreme levels of exercise. Health consequences from the fairly benign dry hair, hair loss, brittle nails, to fainting, extreme fatigue, muscle loss, overall weakness, abnormally low heart rate, low blood pressure, risk of heart failure, severe dehydration, kidney and organ failures, osteoporosis, and osteopenia, which can lead to broken bones. Bulimia is different in that it's characterized by binge eating and then compensatory behaviors such as vomiting, laxative use. Again, excessive exercise also counts. So self-starvation, exercise here, binging, and then exercising to compensate for the amount of calories. What's another characteristic that's fairly common is feeling out of control during their binges and then feeling extremely remorseful after. Most people struggling with bulimia appear to be of average weight. So again, you can't really tell if a person has an eating disorder based on their weight. The signs, the warning signs here would be frequent trips to bathrooms after the meal, excessive rigid exercise regimen, compulsive need to burn off their calories, discoloration or staining of the teeth. For those of you working in the dental field, you see erosion of the backs of the teeth or maybe ulcers in the throat or the mouth. Withdrawal from usual friends and activities, continued exercise despite an injury, calluses on the backs of their hands and knuckles from self-induced vomiting, getting that stomach acid on their hands and then a repeated burning. The repeated purging cycles affect the entire digestive system and lead to electrolyte and chemical imbalances that affect the heart and other major organs functioning. Electrolyte imbalances leading to an irregular heartbeat and possible heart failure and death. These imbalances are caused by dehydration, loss of potassium, sodium, and chloride. You can also experience a gastric rupture during binging, inflammation and possible rupture of the esophagus, vomiting, tooth decay, and staining of the stomach acids, staining from stomach acids on the hands or skin, chronic irregular bowel movements and constipation as a result of constant laxative use, and the calluses, as I mentioned, are already. Binge eating disorder, BED, is probably the most common of the eating disorders, although not as well known and often confused with bulimia. It's characterized by recurrent binge eating, but it differs in that there's no compensatory behavior. There's just the eating periods. Person feels out of control after the binge and distressed by it. The most common eating disorder in the United States. It's often misunderstood as just overeating. And it's not a choice again and has significant psychological impact. Person struggling with binge eating disorder can be of any weight or size. There's no correlation between binge eating disorder and weight gain. We're all built differently based on the variety of factors, so looking at a shorter person with more weight or a tall person who's thin or vice versa. Warning signs here are secretive behavior about eating or binging. Well, there's no binging in there. Yeah. Yes, binge eating disorder. Okay. I was thinking purging as I was saying binging. Secretive behavior about eating or binge episodes. Repeated episodes of dieting or attempts at weight loss. Large amounts of food may be missing from the pantry or found in the trash. Larger than normal amounts of money is spent on food. They have secret stashes of food in the house or empty wrappers that you find in different places. And the health consequences here are musculoskeletal problems, gallbladder disease, high blood pressure, high cholesterol, heart disease, and type 2 diabetes related to insulin resistance. Avoidant restrictive food intake disorder. This is characterized by extremely, or can be also called very picky eating. Those struggling may develop a lack of interest in food or experience unexplained body discomfort. And they kind of start at having a food that's unacceptable and then broadening to a whole category. So they might start with ice cream and then go all the way to no dairy products whatsoever. And then narrowing and narrowing more over time. Warning signs: restricted or reduced food intake, frequent complaints about body discomfort with no organic cause, lack of appetite or interest in food, fear of negative effects of eating, fear of eating, choking or vomiting or feeling nauseous while they're eating, inability or reluctance to eat in front of others, and then again, picky eating. Health consequences here can be in children a failure to thrive, anemia, weight loss, gallbladder disease, and malnutrition, which then impacts their hair, dry hair, hair loss, brittle nails, and difficulty concentrating. All of these are going to affect the brain since they all affect nutrition. Again, osteoporosis and osteopenia. Other specified feeding or eating disorders. It's a broad category. It includes conditions that do not meet criteria for any of the other ones that we've discussed, but still cause significant distress. So again, it's kind of a catch-all category. For example, in atypical anorexia nervosa, all of the criteria for anorexia is met, but the patient's weight is not below normal. Perhaps they started at a higher weight, and they haven't reached a point at which their BMI is too low. The self-starvation and disordered thinking are psychologically and physically destructive and must be addressed, but it's important that OSFED is recognized on par with other eating disorders and that its seriousness is not underestimated. Warning signs here: preoccupation with weight, but not as consistently as found with other eating disorders, increased isolation, depression, or irritability, compulsiveness, and obsessive exercise. All of these disorders will probably come with a co-occurring disorder, something else that impacts the disorder and may have had somewhat of a causal effect. Many of those people struggling with eating disorders have such things as anxiety, substance abuse, obsessive compulsive disorder, depression, or post-traumatic stress disorder. All conditions should be identified and treated by someone who has expertise in both eating disorders and the co-occurring condition. Up to 50% of individuals with eating disorders abused alcohol or illicit drugs at a rate 5 times higher than the general population. And depression and other mood disorders co-occur with eating disorders quite frequently. Up to 69% of patients with anorexia nervosa and 33% of patients with bulimia have a coexisting diagnosis of obsessive compulsive disorder. So this becomes the compulsion that they have to go through, or the obsession is about their food, their weight, their body size. Health consequences of all conditions here impact cardiovascular, muscle tone, risk of heart failure, bradycardia, slow pulse or heart rate, which can sometimes be confused with that of an athlete, which will oftentimes athletes will have a low pulse rate, but it can also be confused with the low pulse rate of a person with an eating disorder. Electrolyte imbalance can also lead to an irregular heart rate, possibly heart failure and death. Potassium plays an important role in keeping the heartbeat and muscles, helping them to contract, but it's often depleted by the purging. Gastrointestinal system, slowed digestion, gastroparesis, food restriction, and purging by vomiting interferes with the normal stomach emptying and the digestion of nutrients, so we can get stomach pain and bloating, nausea and vomiting, blood sugar fluctuations, blocked intestines from solid masses of undigested food, bacterial infections, and so on. Sometimes the constipation is due to the fact that there isn't very much food to move through the system. And sometimes it has to do with weakened muscles and having very little strength. Laxative abuse can damage the nerve endings and leave the body dependent on laxatives to have a bowel movement. Neurological, I think this is one of the most important things. On a college campus, the brain consumes up to 1/5 of the body's calories. Dieting, fasting, self-starvation, and erratic eating means the brain is not necessarily getting the energy that it needs, which can lead to obsessing about food and difficulties concentrating. Extreme hunger and fullness at bedtime can impact sleep, which also impacts the cognition. Body's neurons require insulation, which that layer of myelin, which is a fatty layer. So if people are restricting their food and their fat stores are being depleted, then they can have neurological issues related to a lack of myelin. Neurons use electrolytes, potassium, sodium, chloride, and calcium to send electrical and chemical signals from the brain to the body. So severe dehydration and electrolyte imbalances lead to seizures and muscle cramps. If the brain and blood vessels can't push enough food to the brain, it can cause fainting or dizziness, especially on standing. We have orthostatic hypotension. One of my nursing words I haven't used in a million years. It affects the endocrine system, so sex hormones, estrogen and testosterone are impacted. Women can lose their menstrual cycle. They can also grow hair, which is called lanugo. I keep pronouncing it Lugano. Lanugo, which is a fine hair that grows on the arms and on the back. That can be an indication in people who have anorexia or self-starve. Thyroid's impacted, lower sex hormones. Over time, it can potentially increase the chances that a person's body will become resistant to insulin and develop type 2 diabetes. One of the categories of people that can quite frequently develop an eating disorder are type 1 diabetics, the people that have insulin-dependent diabetes. Anybody figure out why that would be? Anybody have diabetes? You're constantly focused on whether or not you're going to have enough food, because if your blood sugar gets too low, you can die. Who saw Steel Magnolias? All right. Other health impacts: low caloric and fat consumption can cause dry skin and hair to become brittle and fall out. So those are some things to look for when you're wondering about someone. To conserve warmth during periods of starvation, the body will grow that fine hair called lanugo. Severe prolonged dehydration can lead to kidney failure. Inadequate nutrition can decrease the number of the types of blood cells, certain types of blood cells, so anemia can develop. And we also have malnutrition that will decrease the infection-fighting cells. Eating disorders have the highest mortality rate of any mental illness. Anorexia is particularly high in the mortality rate. The numbers underscore that eating disorders must be treated as serious illnesses. People can and do recover, however, and acknowledging the seriousness of eating disorders and the importance of recovery can be the first step in the process for someone. Moving on to getting help and seeking treatment. Just as I mentioned before, eating disorders have the highest mortality rate of any mental illness. While seriousness of eating disorders should not be underestimated, eating disorders are not hopeless. Treatments available and recovery is possible. Early intervention is vital. The earlier a person seeks treatment, the greater the likelihood that they will recover. Detecting and treating eating disorders as soon as possible can save lives. And after this, we'll go into some of the resources that we have locally, as well as the online screening. So this would be the trajectory of eating disorders treatment. We have intervention, professional treatment, ongoing support, and then recovery. None of these are straight lines, and that's because just like any condition, people may take a step towards recovery and then take a step back. And that's a natural part of getting help, of going through change. How many people have seen the stages of change model? A few people? So you know that relapse is a part of the stages of change, and it's expected. And it shouldn't be shamed or blamed or anything like that. It's a part of that person's process. We want to emphasize the need for professionals throughout this process and professionals who have a specialization in eating disorders treatment. Ongoing support from friends and family is vital. These are very complex illnesses, and compassionate support throughout the treatment process is essential. It can be very difficult for family members or friends of somebody with an eating disorder to feel that compassion if the person's been chronically ill for a while, and depending on the nature of a co-occurring disorder that they might have. But it's imperative that we help people see this as a disorder, as a mental illness, as a condition, rather than see it as a person making choices, because they're not necessarily doing that. The need for individualized care is extremely high. There's no one-size-fits-all for this. It's important to work with a treatment team, at least specially trained professionals, to identify both the type of treatment and the level of care that's necessary. The initial assessment and diagnosis is meeting with the medical professional, reviewing different treatment modalities and approaches, and determining the level of care needed. Interviewing providers, it's very important that people don't just find a person and say, this is going to be the person that we're going to work with. You need to interview the care team. You need to look at the facility that you're considering going to. What fits that individual's needs the best? Recommended treatment involves a multidisciplinary team of professionals, so therapists, nutritionists, psychiatrists, and physicians. It's important that there's good communication throughout the process and through all of the professionals involved. Connect with your insurance provider regarding coverage. We had this parity discussion about mental health and physical health and how mental health should be covered on par with physical health conditions, and I don't know that that's necessarily happened. So there's different levels of coverage. Even though you might have a PPO for your physical health, your mental health could be a carve-out where the company contracts with another company to provide the mental health care. And sometimes that can have additional restrictions and requirements on that particular plan. There are also sliding scale fees for different facilities. You also have the possibility that a person may apply for Medicaid and receive treatment there. Again, different conditions will be treated differently, perhaps. And then developing a maintenance plan, coordinating with the treatment plan team to ensure the ongoing treatment plan is followed, and particularly after stepping down from one level of care to a lesser restrictive level of care. That's usually when people have more difficulty, because they might be really comfortable at staying in a residential facility where everything's controlled, and now they're going to get out, and a lot of their triggers are out of the place that they're in. So now they have to start to experience those triggers and not cope in the ways that they have. Again, support from family and friends is extremely important. The levels of care, we have inpatient. Now, inpatient is different from residential in that we are talking about a person who's medically unstable and psychologically unstable. They need help. They may have acute health problems, heart problems, all of that other stuff. So this is where we're focusing on the body first to get it healthy enough. We have residential treatment where they're medically stable and requires no intensive medical interventions, but the person is psychiatrically impaired and unable to respond to partial hospital or outpatient treatment. Partial hospitalization, this gets confused with an intensive outpatient program. Partial hospitalization is a longer period of time each day is spent in a program, but they are allowed to go home at night. Intensive outpatient is different in that it's usually fewer professionals engaged as acutely or as frequently. It'll often be like a support group that a person will attend for several hours, a few hours a day, and then again they're able to go home. And then we have outpatient. An outpatient is usually focused on maintenance. There may be different relapses that they're going to deal with and try and deal with without having to put a person back into a more intensive level of care. So the level of medical stability and psychological stability increases all the way down. You need a higher level of stability towards the bottom than at the top. Where to find help, supports, and resources. This came to us from the National Eating Disorders Association, and they have a helpline. It is not open on Saturdays or Sundays, but it's open 9 to 9 Monday through Thursday, 9 to 5 on Fridays. The Click to Chat, again, the same schedule, and that is a web-based chat through their website. You click on a link, and that'll open the chat box. And then a crisis text line, 24/7, 365 days a year, that's covered. And you text NEDA to 741741, which I think is actually the same crisis text line that's used for suicide prevention and also for vets who are in psychiatric distress. It's the same number, you just text a different set of letters to get the kind of person that you need. Eating disorder screening tool. This is available through NEDA, and it's nationaleatingdisorders.org/screening-tool. Anybody can take it. It's anonymous. 96% of the people that have taken that have been 70% were under 25, and 96% were identified as at risk, but only 86% were not already in treatment. No, sorry. 86% of them at risk were not in treatment. 1 in 5 of these helpline contacts who were looking for treatment options reported that there were barriers for them to access care, either fear of reaching out, the cost of care, etc. And participants who screen as at risk will be directed to NEDA's helpline and other resources for help. NEDA also puts together toolkits for educators, parents, and the coach and athletic trainer toolkit, which I think is really great. I'm waiting for the health professions toolkit. How can you help people? If you're trying to approach someone, you want to learn as much about eating disorders before you approach them as possible. Be honest and vocal about your concerns. Be caring. They say be caring and firm, and I say be caring but firm, because I think a lot of times we think if we're caring, we can't be firm, because that's going to be tough on somebody. Suggest they seek help from a physician and or a therapist. Be a good role model and practice what you preach. If you're sending them, is there something you need to be taken care of as well? Sometimes in living in a family where there is someone with an eating disorder, there can be dysfunction either before the eating disorder was developed, or there can be some after, because the people don't really know how to address it and how to cope with it. So it's good for people, if you're concerned about someone who has an eating disorder, it's helpful to you to go and seek help as well, so that you can deal with your emotions, so you're not trying to deal with them through the person who has an eating disorder. That's not fair to them. We don't want to shame, blame, or place guilt on people, make rules or promises, give simple solutions. This is a complex illness. Invalidate their experience or try to convince them that they have a problem. I think that's one of the toughest things, is people see a problem and they're trying to convince somebody that there is a problem, and it becomes a power struggle. Don't give advice about weight, exercise, or appearance. It's good not to even bring up appearance. But you look fine. You know, you're not heavy, whatever the comments might be. We also want to stay away from identifying, like if we're talking about a story, somebody we know or an experience that maybe we've had, to stay away from things like, oh, well, this person got down to X weight. Because for people who are actively in an eating disorder, that can be sort of like, well, if they got down to that weight and they were alive, then I could do that. Or it's sort of a competitive thing. Well, I can do that and more. Especially, we don't want to ignore or avoid the situation until it becomes severe or life-threatening. I don't think this other video is going to play for us either. Oh, I moved it. Good. Talking about eating disorders, keep in mind, no tips, no numbers game. That's the so-and-so got down to this weight. emphasize the seriousness of eating disorders without portraying them as hopeless. You don't want to bring up the worst case scenario that you might have heard of. Watch out for the appearance ideal, and by that we might mean the social validation of a particular body type. You don't want to focus on images or descriptions of a body at its unhealthiest point. You notice in this presentation there were no pictures of anybody severely underweight or overweight. The Body Project is from NEDA. This is one of the few evidence-based intervention programs that provides a forum for women and girls to confront unrealistic body ideals and engages them in a development of a healthy body image. It's a 4-week-long program. During that process, the participants will critique that body ideal through a series of written and verbal and behavioral exercises. The program improves negative body image, reduces maladaptive dietary restraints, and reduces early-stage eating disorder symptoms. Data suggests that for every 100 high-risk young women who complete the program, there should be approximately 9 fewer future cases of eating disorders. That's a pretty good return. An endorsement from someone. Now that I've done the Body Project, I've noticed that I see my body more positively now, and I stay away from negative comments. I'm also doing this with my family members and staff around me. Our local eating disorder resources. Next week on the 7th, which is Wednesday from 12 to 1, we will have someone from Rosewood come here and give you part 2. We're going to have a panel group. We're going to talk to you about their experience living with eating disorders. So if you can come to that, please do that as well. They're located in Tempe. They also have an inpatient facility in Wickenburg. So does, let's see, it's another one that I didn't put down. It's a ranch. Does anybody know the name? Can't think of it. I don't know why I didn't put it down. But there's another in Wickenburg that also has, it used to be a religious-based program, and now it's not. The Meadows is an outpatient center. That's in Scottsdale. You notice these little symbols here, and that means that their inpatient program is accredited by the Joint Commission. So again, the Meadows has an outpatient center in Scottsdale, but they have an inpatient center somewhere else. And then Healthy Futures is, I believe, an outpatient only. So they're going to do the outpatient partial hospitalization and intensive outpatient program and individual therapy. A New Beginning is also in Scottsdale. A lot of Scottsdales in here. New Beginning is also outpatient. Desert Milagros is down in Tucson. And Cottonwood in Tucson is the only CARF accredited. That's a rehabilitation facility accreditation. I'm going to try this and see if we can get this one to open. This is a how to help a loved one video. I see you trying.
Recovery is real. Help is available.
People often notice that a loved one or a friend is changing their eating behaviors or their attitudes toward food, towards weight, towards their size, towards themselves. It's really important to express your concerns about this in a loving and caring, supportive way. But also it's important not to wait too long, because the longer an individual is walking into the path of the eating disorder, the more physical and emotional consequences they'll need to face.
Learn about eating disorders so you will recognize the signs when you see them and know the difference between myths and facts.
Set aside some time to have a private conversation with your loved one and voice your concerns in a way that's honest and sympathetic.
Remind your friend and your loved one that you care about them and you just want them to be healthy and happy.
Be prepared for a difficult conversation. Someone who's struggling with an eating disorder is already scared, and it's extremely difficult for them to hear this kind of conversation. So when you do it with love and attention to their needs, not yours.
Share your own difficult experiences and painful emotions. It can be really important for them to know that they're not alone and that there's nothing wrong with them for struggling.
Don't give advice about weight loss, exercise, or appearance.
Avoid placing shame, blame, or guilt on your friend regarding their actions or attitude.
Don't oversimplify. Avoid saying things such as, if you just started to accept yourself, everything would be all right. Or, if you just started eating normally, everything would be fine.
Use I statements. For example, I'm concerned because you don't eat breakfast or lunch, or it makes me afraid to hear you vomiting.
Set boundaries to preserve your own emotional well-being.
It's important to suggest that they seek professional help from a physician, a dietitian, a therapist, someone who understands eating disorders.
One of the most important things you can do is educate yourself about eating disorders. Dig into the facts. Go to the NEDA website. There continue to be lots of myths and misconceptions about these disorders, and you need to educate yourself about what's true.
I know I'm not the only one that struggles with body image and eating disorders.
My life in recovery is more beautiful than I ever thought possible, but I had to make that commitment to myself.
So I'd like to encourage you to get more involved with NEDA. You can use their business line there, the helpline for information for yourself or a loved one. A lot of resources exist on their website. I've downloaded most of what you've seen today, and there's a lot more. Any particular questions that people might have? Yes. Not that I'm aware of. I'm sure there's been some research done, but it's difficult to get any behavioral health information about healthcare professionals in training because they're fairly small groups. There's been a lot done with medical students related to drinking and drug use, but when you get into like other professions, it becomes more difficult. Now, athletic training, we typically assume athletic trainers, and I assume that a lot of PTs have also been athletes in the past. So I see that as an area where if you looked at the data from athletes, that gives you some idea. It's not going to be, correlative, but at least you have some idea of how it might be affecting students in those programs. Certainly stress. When I say that word, all the students go. Certainly stress is a factor that can be involved in developing an eating disorder. Other things have to exist as well, or related to someone relapsing in any mental health area. Yes? I also have a video that is called Get Real, Realistic Expectations and Attitudes for Life. And this came from the hopetolive.com program. I think I got it from Remuda Ranch. That's the name of the other place in Wickenburg. So Remuda Ranch has been a part of this. This video is available in my office. If you check it out, I'd like it back. I seem to develop a library that just goes one direction, goes out the door, and it doesn't come back. That was her own restriction. Yeah. Mm-hmm. Mm-hmm. And some of the compensatory behaviors that I've seen adolescents and young people use is to dress in very oversized clothes so that other people can't get an idea of what their body shape is. It could be necessarily that they intend for other people not to notice, but they themselves don't want to notice. And if they're dressed in a very oversized clothes, well, that's the way it's going to look, no matter what my body size. Yes, ma'am. If you're concerned about somebody needing help, I would suggest the physician, the primary care first, therapy, and then leave the nutrition out of it, because other people will bring that up. And hearing, oh, you're going to make me focus on food. I think that's one of the first referrals, is to say, well, have you talked to a nutritionist? Because they may have done a lot of their own research about food. They often know how much calories is in everything, and just how much of it they can have. So getting them to the other folks that will identify the problem would be the primary goal. There's a lot of notes in here that I didn't want to read to you because it was taking too long. If I can find it, I can send it to you. It's a very high percentage, and the percentage of men is going up because the effects of advertising and images and things like that is impacting men. Sometimes LGBT men before heterosexual men, but it's hitting everybody, really, when you have that sense of what's the perfect body. Thank you. It's the same time, 12 to 1. And that, again, will also be recorded and on Zoom. So I think if you... Did you guys get the email? Yeah. Good. Yeah. Or yesterday. There was one I sent out yesterday. There's a link that was in there for the Zoom if you want to do that. Thank you. Ooh. That's going to be in SAG B. Yeah. Well, yeah, and with me developing or being on the border of developing type 2 diabetes, you get hyper focused on what you're eating and am I gaining weight and all of that. Oh, I got to turn this off.